All right, so this evening I wanted to focus on E&M, and we will cover Hcpcs and medicine next week. Start on those particular sections, but tonight it's really important that you understand evaluation and management. And while I'm able to control everything, I figured this would be a good way to make sure I'm able to cover all of the content. So what I will do is go through the presentation, and then throughout the presentation, I'll open the line for questions. And then, I will go back into the presentation, and then towards the end, a little confused. But if you have your book in front of you and you're able to follow along, I believe you'll be just fine. I also sent out the index information. The earliest it was sent with the email with the link. So other than the April 29th exam date, the next one will be on May 31st. So it's up to you. If you're going to, then you need to make sure that you're registered by, I believe it's going to be next week. You need to be registered by the 15th of April. And because I'm not at the office, I don't have my 2016, so we're going to have page 1. E&M is basically the first chapter in the CPT manual. And again, I've always stated that it's located there because it's going to be the most frequently used chapter throughout the CPT manual. All right. So tonight, my goals are to give an overview of E&M, for you to understand the difference between new and an established patient ideas. And then what we're going to end with is how to properly level an E&M service. So again, E&M stands for Evaluation and Management. And we will break one of the things about this particular chapter is that it doesn't have to do with anatomy and physiology. It's basically where the services are being rendered to the patient, right? So that should be an easy concept. And everyone can see the screen. Just want to make sure you're seeing the PowerPoint, right? So when we talk about evaluating and manager is assessing you, right? So he's going to observe, he'll maybe hit the knee, see your reflexes, listen to your breathing, that type of thing. That's all part of evaluation and management. And evaluation and management is also basically, it depends a lot on the patient and the provider. Now you see I have my stars up here because these are the important steps when it's time for you to choose. Part of the presentation will be item number 6, where we are going to select the level. So here's the thing, if you have a question, just make sure you type it in the chat box because I'm using my phone to talk. But if you send me a private message, you can just select down on the bottom right-hand side. Instead of sending your message to the entire classroom, you can hit the drop down and just I'll see it pop up on the screen. Otherwise, I'll be looking at my phone and talking. Just make sure so I can address it. You can use the chat box. Okay. So the 3 key components they used to like to ask this on the exam would be items 3, 4, and 5. That's where we're going to spend a lot of our time when it's time to level. So we're going to determine the level of history, the level of the exam, decision making. It's the key components. They call those the 3 key components: the history, the exam, and the medical decision making. That's going to be the hardest part for you guys as far as the leveling, but I have a few little tricks, sure you understand it. The first thing you always want to remember is it's like a who, what, where type questions, like where is the patient? Have they been seen before? So let's get started with this. So again, you'll notice that on this page, just like with your other chapters, your reference pages, with evaluation and management, there is a top portion that says evaluation and management service guidelines, and then there's the other half, and you'll see office or other outpatient services. Right? So the top half of it is what we're going to cover towards the end, which is all of the items that we're going to cover to Hcpcs level. But if you're looking at the bottom half, you'll see that the green, everything that's in green, are going to be your places of service, right? So if you turn the page, there's office, hospital, observation, inpatient, and then consultations, the ER, critical service. So you can see all the different service. So again, the first thing you always want to do whenever you're reading a question is to figure out where this patient is, right? So where's the place of service? Once you are able to locate your first 4 CPT codes, numbers in your CPT selection, right? The last digit of your CPT code is going to be the level. So that's why I say it's always going to be easy once you understand whether they are new or established, if that location has that requirement. All right. So on this particular slide here, you can see, so an office visit, there's 2 categories. There's 2 categories for office visits, right? So you can see on the left, you have a new patient. And you can see that the first 4 characters or numbers, I can say numbers because we're talking CPT, the first 4 numbers are going to be 9920, right, for new patient. And then if you look at the right, at established, are 9921. Okay, so I would say, they've been here before would be a 1, or they haven't been here before would be a 0 for their 4th digit, in reference to new and established patients that are coming into the office. Sometimes they won't say office, aka clinic. Okay, so maybe a clinic setting, maybe an urgent care. Even in the emergency room, office visits can be provided in the emergency room. That's considered a patient place of service. Okay, but the ER, if E&M is rendered in the emergency room itself, if it's an emergency condition, they do have their own CPT code, but have had some type of provider visit in that particular location. So just remember, if they're in the office, if it's a clinic, if it's like an urgent care, then it's going to be considered an office for the new patient, and 1 if that patient has been seen before. So then you may ask, let me go back a second. know the difference between a new patient and an established patient? So a new patient is basically someone that has never been seen before, right? So the key here, or the key number, so 3 years is the key. So if I've never been seen before, so I'm going to have the 0. However, the reason I say 3 is the key, because you can be an established, once you, and now you're going back, like a follow-up visit, you're now an established patient. Well, what if that established patient took a hiatus and then they came back? If that established patient provider's office, okay, over 3 years, so remember they're established, but if they've had an absence and they haven't gone to the doctor for about 3 years, so you always want to look at the time, how long it's been since their last visit, right? So if they say, oh, patient was here last month, then you know they're still established. But if they say patient was here, today weren't here since 2013, then they go back to being a new patient. And a lot of providers will just have patients enrolled in their system as being established, and they've taken office. When they come back after that gap of 3 years, they're now considered a new patient again. So that's important for you to remember. Okay. Does anyone have any questions about this established patient and what the time frame is? You can type. You can always type if it's a question that you think will help everyone. Please make sure. Yeah. Okay. Office visit and urgent care. So what I'm saying with the urgent care and the office visit, it's still going to be, they're still going to use office visit codes. Okay, so office visit codes, there'll still be, because people will do a follow-up at the urgent emergency room, and urgent care is not an emergency room due to the fact that they are not on the hospital facility and attached to the hospital itself, right? And then you think about the ER. The ER is open 24 hours a day, and urgent care actually has it. So that's the difference. One other thing I did want to mention, sometimes there is a provider's office that has multiple the same specialty. If the provider has this, like let's say it's a 3 internal medicine providers, and let's say there's also a gastroenterologist in that practice. The gastroenterologist, right? So although they're still going to, let's just say, Henry County doctor's office, although they all work under the Henry County doctor's office, is not the same as the internal medicine doctors. If that patient has only seen the internal medicine doctors and now they're going to see the gastroenterologist, they're going to be new to that. Okay. Or maybe they would be sending that patient over to the gastroenterologist as a consult, and we'll talk about all of the different visits in just a moment. Care uses office visit code. That's right. So just so you know, they won't ask about urgent care. Or if they do, at least you know which code range. Okay. So again, so if they see Dr. S one day, and he's an internal medicine doctor, and they see Dr. K the next time they come back, they're same specialty, within that practice. Okay? But if they see a provider that is of a different specialty, then they are new to that particular provider. Okay? So I don't want you to, first thing I want you to do, like I have here, is to look at CPT code 99201. 99201. So everyone should turn to 992. Okay, so I see a question. Can a new patient E&M be billed if the patient is seeing a different physician? Do you mean different specialties? I need to know if you're talking about different specialties or same specialty. If they're both internal medicine doctor practice, then that patient is established. Or you saying the patient hasn't, because it's the patient coming to the patient. If they're new, then they're new. I just want to make sure I'm answering your question. Because when you say a new patient, if they're a new patient, that's what they are. But if they are a patient that was new, that has the same specialty, once they come back, then they're established to that. Okay. So if they're new to that physician, but not new to the facility, but locally, then that patient would be established. As long as they haven't, so many factors, as long as they haven't had that gap span of over 3 years. I hope that answers. Okay, so again, if it's a different specialty, then in the same practice, then that patient is new to the new specialty. As you can see, if I say 9920, you already know that that's a new patient, right? You just don't know the level based on the question. But here's what I want you to pay attention to in your book, right? And it will be bolded in your book. Remember the CAM and the medical decision making? When the AAPC gives you the exam, right? For the most part, they're already going to tell you patient had a problem-focused history and whatever type of medical decision making, because you'll see that they're going to vary based on the level. If you look at 99202, you'll see an expanded problem-focused history, an expanded problem examination. You see those. With 99203, you see it now becomes detailed, and your medical decision making, sometimes they'll say MDM is of low complexity. Comprehensive, okay, and the medical decision making is of moderate complexity. And then with 05, you see it's comprehensive, and high for the medical decision making, right? So highlight what you're looking for with E&M questions is, let me highlight the history. Well, first of all, you want to highlight where they are so you can get to the right page, right? And then you want to highlight what the level of the history is, the level of the examination, and the level of the MDM. Few questions. They give you very few, but I still like to go over this with you, because if you are interviewed or you have an opportunity to code E&M, you need to make sure you understand these levels. and I just got straight E&M jobs within the last week or so. So this is very important. The main thing is a lot of people don't focus on it, but it's important to understand how we get those bolded levels. And that's what we're going to cover towards that. Already going to tell you, right, what the level of the history is, the level of the exam, and the level of the MDM. So let me, we're gonna be interactive right now. I want you to type your answer in the chat. So what if a patient had a detailed history and exam and a medical decision making of low complexity? What would my CPT code be? Detailed his decision making of low complexity. I'm seeing answers. Yep. Good. The correct answer would be yes, 99203. Some of you are like, oh, I like this. Okay, just hold that thought. We got to get to the leveling. But for the most part, this is what we're doing, right? So it would have said, okay, that's an office visit, right? So you see at the category at the top on the in the PowerPoint, it does say office or other outpatient services. That's what I was saying. The ER is exactly what's being provided in that location. Because remember, outpatient is when you can be seen and you can leave the same day, right? So we're going to talk about this, but right now we're just focusing on office visits. Okay. So the next one I have, what if it is a comprehensive history and examination, but my MDM is of moderate complexity? Answers in the chat box. I want the complete answer. Yeah, we know the level, but I want the whole code because we're talking about the office visit. So you have to make sure you're telling me the office visit code along with the level. Which would okay, I see you. So make sure you always give me the complete code because you could say level 4, and I'm like, well, I can't do this right now. I will take that, but always make sure that you enter the complete CPT. One trick that you need to know for new patient, right under you'll see it says it requires these 3 key components, right? So if you're a new patient, you have to meet these 3 key components. Have a detailed history and a detailed exam, but their MDM was straightforward. What would my answer be? Because it just says here, detailed history, detailed exam, and my MDM is straightforward. Someone put the answer in the chat box for me. Make sure we stay where we are. That we're not even in that category yet. So just hold on. Yes, 99202 would be the correct answer because if you're not able, this is in reference to a new patient, and then we'll talk about established. If you're not able from 99203 and then one falls back to 99202, you're going to drop back one. Not all the way. You're not going to skip 02 and then go straight to 01, but you're just going to go back to 99202. Okay? So just remember, can't meet all three, you drop back to the lowest. Or it could have been a problem-focused history, expanded problem-focused examination, and a medical decision curveball at you guys. What would that answer be? So you're going to do 9. Okay, so we have a problem-focused history, examination, and a medical decision-making of low complexity. Remember, if you cannot meet all three, you're going to drop back to the lowest. So remember, I said drop back to the lowest, and I asked those to what level? Correct. The correct answer would be 99201. So you have an idea of where I'm going with that. So with the new patient, if they're not able to meet all three of those key components, so you just have to see what category it's in, and that's how you would choose. So again, let me just remove this, get this out of the way so I can see my slide. Has not received any face-to-face professional services from the physician, qualified healthcare professional, or a physician qualified with the exact same specialty. Sub-key number there is within the last 3 years. Okay? So an established patient has received services in the last 3 years. Pretty plain. Just remember to number so that you can remember 3 years is the key. But it also is in, if you notice in the E&M section, there are a few green pages, which we will go back to when we're doing the leveling, like before page where everything starts. And well, let me talk about established, because they didn't talk about established. And that's important. So turn to an established code. So established is 992, and it goes all the way through 99215. But you'll see with 99211 through 99215, you'll see it still has the bolded key components. So you have the understanding of how to use those key components. So here's the thing, 3 out of 3. If not, then you drop back to the lowest, right? With an established patient, you only have to meet 2 out of the 3. Look at the definition on CPT code 9921 like that. So you can just see that last sentence says, which requires at least 2 of the 3 key components. Okay. So that means if I had an expanded problem focused history and an exam, regardless of what the level is for my MDM, my answer is still going to be 99213. Right? But here's the kicker. Remember when I gave you the example where I took one from, I'm going to use levels, because if you notice 992, do you see that? But with 99201, it does. So usually 99211, that's like when someone's coming in just to get like a blood pressure check, that type thing of reading, because there's no E&M component to it. Okay. So it's you see the definition here it says or other qualified healthcare professional. So 99211, usually I just write nurse next to it, right? Because the doctor's not really, it's, okay. And I'll talk about time and all of that also in a little bit. But let's say for an established patient, there was one component from level 2, one from level 3, and one from level 4, right? With an S that's in the middle, right? So if I had 2, 3, and 4, I would have to choose 3. Does everybody understand that? Yes, Jasmine. I don't know if you got on the call a little late, but we will be covering the leveling towards, everyone says no. Okay. So let's say, look at 99212. Let's say it was a problem-focused history, and they had a expanded problem-focused examination, which comes adequate decision-making of moderate complexity, which comes from level 4. Well, remember, with the established, you have to have 2 out of 3, right, to pick the code. But in this situation, level. So if you don't have 2 in the same level, then you would pick the middle. Then you would pick the middle of that level. So if it's 2, 3, 4, you're going to pick the 3. Does that, for example, yes, okay. I see some yeses. Repeat, yes, yes. Okay. So if a level, if there's a component from level 2, it could be the examination, or a component from level 4, which would be the moderate complexity, then you would choose level 3, right? Same thing. It could be, if I have one from level 3, one from level 4, and one from level 5, what is my answer going to be? Chat box. All right. I know you're getting it. I saw a 0 there. This is established for your 4th character. All right. So we're moving over to the next one, which is hospital observation. Guys, please make sure you mute your button because I can hear background noise. Just press your mute button. Thank you. All righty. So we're moving on to observation. So we're good. Okay, hold on. I see a question. What do we decide on if the level varies? It won't skip from a 2 to a 5. Well, even if you went 2, 4, and 5, where's your middle code? So you're going to go to the middle. The level is the last number. The level is the last number. Again, if you're picking from 3 numbers, if you're picking from 3 different categories, it doesn't matter how you spin it, right? You have to have a history, an exam, and medical decision making. Not score 2 in one of those levels, then you're going to have to pick the middle one. Okay. Wonderful. Glad you're getting it. So I think we're good. I think we're good with office visits. Now, moving on to observation codes. Can be a little tricky, but it's really not if you do some writing. Okay. Some people, I'm going to tell you, with that E&M, some people actually, next to those bullet points, they like to write in, history. They call it the HEM, right? So they'll put HEM next to each of the dots. But if you just remember, they call it, H is for history, E is for exam, and they'll have. So when you're reading your question, you can put those, either one of those acronyms, so you know which what you're looking for when you look back in your book. But for me, it becomes repetitious. But so what if you feel like that would help you? But I think it's fine to just kind of what you're going to do in your head anyway is say, okay, where's the place of service? So once you already know the place of service, you know what the next step is, right? Is to determine the level, right? Now, moving on to hospital observation. So hospital observation means the patient is in observation status. Okay. When they say they're admitted to observation, is not the same as being admitted inpatient. Observation, they're just being not, if they're in observation, maybe they're not there longer than 24 hours. Well, actually, about 3 years ago, the CPT came up with subsequent observations, right? So you can actually be in observation for up to 72 hours. Okay, time that the patient went in and the time when the patient went out, was discharged. And the reason I say that, because they have observation care that comes in once, meaning they could have come in, let's use the 24-hour period. They could have come in at 7 p.m. tonight, which is April 5th, but they were not discharged until 3 a.m. April 6th, right? So you have to pay attention to the date and the time that the patient comes in and when they're actually discharged to leave, right? So you know what date, what code to use. You were on observation, so I want you to look at CPT code. There's 99217 and 99218. And what makes it user-friendly for me, which is kind of reversed. You would think, no, 7 means in and 8 means out. But for the CPT, was when they're admitted into observation. And the 99217 is when they're discharged. Right? So that's when they're discharged. Now, right above, so what you can do next to 99217, just write out there, out. And next to 99218, you can write comes in. And make sure you highlight observations so you know we're talking about observations. So this means in and out, in one day, out the next day. You might want to write that at the top of that page. In. Now, if you look at the little description right above 99217, you'll see that they have a code range 99234 through 99236. Right? That's that code range. That means they're in and out on the same day. So if you want to really quick, we can turn to 992 since it's in the same, we're still talking about observation. 99234. And it goes all the way through 99236. Right, for observation in and out on the same day. So on top of that page, you want to put in and out, set. So again, how do I know what level? Because as you can see, you still got your key components bullet pointed. All right, so we see that, right? So again, and I'm going to come up with, I guarantee you there's 10 questions, right, on the exam in reference to E&M. Because we're outpatient coders, you know for sure they're going to ask you about office visits. So you need to make sure you understand the difference, and you also need to remember which one needs 3 out of 3 and which one needs 2 out of 3. I don't need to repeat it because it's also in the description of the CPT code. Right? So just make sure you highlight that. With a new patient, you need to meet all three to use that code, right? If not, then you're going to drop back to the lowest, right? And if it's an established patient, these components to use the code. If they're scored in 3 different levels, then you're going to pick the level in the middle. Okay, does everybody understand that? Yes? Yes? Can I see some more yeses, please? And I'll open up the line in just a second. I just want to make sure. But the typing seems to be fine. Make sure I get through this with you guys. This is your favorite too. Okay. Hospital observation services. Okay. So we spoke about that. Observation. We also spoke about if the patient is code range is supposed to be, or if they're in and out on the same day, what that code range is supposed to be. I know we have a couple examples coming up. So what that means, okay, so once, let's say they came in today, which is April 5th, and they discharged them on the 7th, because it can't be more than 3. To being admitted, right? You're always going to code your final destination, right? So if they started out in observation and the same day and they ended up in as an inpatient, I don't want to, like, let's say you went to the doctor's office. You went into the doctor's office and he's like, okay, you need to have your appendix out. And I'm an established patient at the doctor's office, right? And he's like, oh, and I'm in excruciating pain. And he's like, get your appendix to the hospital because you need to have surgery in the morning, right? So if I left from the doctor's office and I'm an established patient, I left from the doctor's office and I went straight admitted me there, then I don't code, well, if I'm going to have surgery the next day, well, you don't code the office, you're only going to code for the hospital because I'd be admitted to the hospital reimbursement and then try to get paid for being admitted into the hospital the same day. See what I mean? And then on my hospital visit, they would put a modifier 57. Modifier 56 surgery within the next 24 hours. So remember that. Jot that modifier down somewhere in your E&M section. Modifier 57 means within 24 hours. And I'll go over a few of the other common modifiers towards the end. All right. So here is one, because I'm going to need you to put your answer in the chat box. Patient discharge. Oh, they only want discharge services. Okay, that's really easy. Okay, because there's only, okay, let's look at the times. Remember, you need to see the times when you're talking about discharge. So the PER. See, this is another one where they started one place and ended up somewhere else. The patient went to the emergency room at 9 o'clock in the evening. They don't have a date. They just have the time. Attention, right? But look at my times. I pay attention to the PMs and the AMs, right? So at 10 p.m., the patient was in observation and stayed in observation for 10 a.m. the following day, they were discharged. So that means what? What category are we in? We're in one day, out the next day, right? So remember that. Now it tells you the fourth bullet point says to end discharge. It says report the observation care code for services provided on the discharge dates. You just got to see what they wanted. Okay. So remember, you had your in one day, out then out on the next day. Good. Somebody's quick. I'm going to have you start sending them just to me so nobody sees the answers. Okay, so when you start, yes. So the correct one, that is correct. And what if they just wanted the code for them being admitted to observation? What would that code be? Good. Yes. Hold on, I think that was a typo I just saw there. So they asked, that would have been 99218. Yes. Perfect. Good. I'm feeling good with this. Some people are lost, but you guys are catching right on. Perfect. All right. Brad, I already spoke about that. That was the in and out the same day, right? 99234 through 99236, depending on what those three key components are. Look at where I have my stars. I should have put those in red. Okay. If a patient, it says use the code from this group when the provider initially chooses to place the patient into observation, right? Again, this would be in and out. 6 is in and out on the same day. 17, well, really it's 18 and 17 because 18 is actually going in and 17 is coming out, but you already know that. So we know that 18 and 17 is in one day, out the next. So I know we got them. If a patient is admitted after admission to observation, that means when I say admitted, means formally admitted. We're going to get a hospital room. We're spending the night. Okay, that's what admitted means. Admitted to the hospital. On the same day, it tells you to use the inpatient hospital care codes. Because remember, you're going to code your final destination. So that means if I was in observation and now they say, okay, you've been in observation for 4 hours, you're not getting any better, we're going to admit, right? We only can code for the admission now to the hospital. So if admitted to observation status in the course of another service, all other services, that's basically like what I said when I was saying you're at the doctor's office and then they send you to the hospital. You can't bill for the doctor. You're going to code your final destination. They're like, you know, they'll put a patient in observation. We can't bill for observation after you had a surgery. You just got to pay $4,000 to do that repair of the hernia, right? So you're not going to get paid patient. Let's try and charge for observation. That doesn't work. All of that money is going to be rolled up into that surgery code. Are we good so far? No questions. Yep, that's a global surgery package. So we're done with observations. We're moving on. And also partial hospitalization. We already know that 3.4 and 3.6 is for admit on, so that means if you're doing partial, because I said it has the inpatient facility and partial hospitalization. So if they're only there, if the a.m. to 4 p.m., then you're going to go back to your in and out on the same day. Remember those. It kind of goes back to the in and out same day observation code. Okay. So subsequent visits while admitted. Well, let's look at some of these codes. I like to talk to you so you can understand them a little better. Look at 99221. Okay, so when you're in the hospital, when you're admitted, the new and established no longer applies. So this is basically every month. You're still going to use these codes. So these are not broken down into new or established, right? Because it's inpatient. So if you look at 99221, okay, one second. Okay, so when you say gets admitted on the same day by a different doctor, is it their doctor? Is it a doctor of this practice? Is it the same specialty? I need more than just. So is it the doctor from the same practice, or is it a different specialty? Just need to clarify that one for me. All right. Once you type that up, I'll answer it. If you just let me, I need more information, because when you say if a patient goes from the doctor's office and gets admitted on the same day by a different doctor, I need to know who said that's going to apply, right? Because if it's a doctor from the same practice with the same specialty, then again, you're only going to be able to bill for the hospital admission. So I just need more clarification on that question. So, okay, so back to the hospital inpatient. So subsequent hospital, please hold that thought. So subsequent hospital care codes used for subsequent visits while admitted. So basically, subsequent hospital is like I could be 221 means I've just been admitted. So these 99221 through 99223 are for admission codes. So they're going into the hospital. Subsequent visits are 99231 through 99233. Right? So what is a subsequent visit? So once they're admitted, right, 99221 through 99223, depending on the key components. And if they're there, like I'm here, I get admitted today, which is April 5th. The 6th discharged on the 9th. The 6th, 7th, and 8th are considered subsequent days. Right? So you always want to see when the patient went in, and then, when they were discharged. And they can be, remember, patients can be in the hospital for like 30, 40 days. It depends on what the situation is. You have to document every day on the level of service that was provided, so you would know what subsequent date, what subsequent code to use for the 6th, the 7th, and the 8th. Does that make sense? 221 through 223 is for the admission, for the patient being admitted to the hospital. That's considered a hospital admission. 99231 through 99233 on the key components. You'll know which one to use. And when they're being discharged, if you turn the page, it will tell you hospital discharge services. And hospital discharge services are basically based on time, 30 minutes or less. And 99239 is for more than 30 minutes. So it will tell you in your question, discharge to 25 minutes. So you're like, okay, well, the discharge is going to be 99238. Okay. Again, is that other doctor part of the practice? Yes or no? Okay. So do they have to internal medical provider. See, we're going to have questions. That's something we're going to have to save until after we're done with this, because I think you may have a couple, a few more, and I don't want to interrupt this whole process. So, all right, want to make sure we get through this, because I do hear thunder rolling in the background. I don't want to lose any power. So again, we know what the subsequent hospital care codes are. So that's the date. So here we go. Here's this is observation or inpatient. Let's see. So a patient comes to the ER in the morning. Important, we know. So patient comes to observation, admitted to observation, feeling better by 8 a.m. So they're only there, what, 6 hours? Lab works okay. Patient's discharged. Okay, it's just telling you your codes would, your answer would come from yes, 99234 through 99236, which is in and out. The CPT code, because we don't have the level, so they're just giving you the code range. So everyone should understand that one. Okay, so they're just saying in and out. They're asking, is this observation or inpatient care? Okay. So observation, but they left, it's in and out on the same day. And again, this is just a reiteration on those discharge services. So remember, your discharge services are based on, so 99238 is for less than 30 minutes. 99239 is more than 30 minutes. Right? So you're always looking for the amount of time that it took for the provider to discharge the patient. Discharge codes, him filling out paperwork, writing prescriptions, talking to the family, make sure they don't do this when they get home, make sure they take their medication. Here's your prescription. Let's see. It tells you something a little different. Discharge of a newborn, right? Because mom had baby has to leave the hospital. Mom came in by herself, but now there's two bodies leaving. So you have to code for the discharge of the baby. Okay. 99463, and that's maybe in the neonatal section. So far, so good. No worries, you'll have study guides and questions coming your way. Right. Okay, consultations. You notice that I have 3 R's. Okay, okay, when you ask would we code for both of them, what are we talking about here? When you say both of them, means for mom, well, remember, mom is going to have her delivery codes. Don't forget we did delivery codes, right? And then we'll code for baby. So that's a good question. That's a great question, actually. Okay. All right. Basically, a consultation, as it says here, stated here, is provided at the request of another physician. Okay. And he's going to either recommend care for that patient. I may say, lump in your breast. And I'm like, I don't, and he's like, but let me send you somewhere for like a second opinion. Okay, so he's going to request, he's going to write it up, which is the first R, request. He's going to session, right? So hopefully he's sending me to someone that's specialized. And that person, that provider is then going to render his services to me, and then he's going to respond back, request, render, respond. And there's another slide that explains that. So I'll repeat it again, no worries. After they recommend, he's going to request another physician take a look at me, and that and see if he recommends care for that particular condition or problem, and see if he's going to take over my care. Right? That's what consultation codes are divided by location. So there's outpatient consultation codes, like for providers' offices, they're going to use 99241 through 992 to be inpatient consultations. That's when you're in the hospital, right? So 99251 through 99255. So again, you're always looking for the place to serve it. And this is a good place. You can always use your, your reference pages to make sure you have the right location. Very important, right? You're coding for the right location. So your inpatient consult and office or other outpatient setting consults, like if you have a consult in the ER, you have to use 99241 through 99245, right? Because you're not formally admitted. That's still an outpatient consult, 99251 through 99255. Again, it depends. How do I know which one to pick? Because you're going to have to wait and see what the provider selects for the three key components. Those R's, there's three R's. And here's the thing, if a patient, like if I decided, if my doctor didn't refer me out to go see another provider and I just went to another, so a consultation is from doctor to doctor. Okay. If I just go to the other provider by myself, then I'm just a new patient to that provider. Okay. I'm just a new patient to that provider, doctor. You have to remember that. And so, because sometimes they'll try and give you a question, and they may put office visit codes in there, and they may put consult codes from your A, B, C, and D for you to choose from. So if you can't see the requester to another one and see that that other provider responded with a written report, that you can't do that. You would be just a new patient to that other provider. And a lot of providers miss this because they do need to have a response, request, proof of the request, the render and the response in order to bill a consultation code. Okay, because consults are going to reimburse higher. So you want to make sure you're just not using consult codes. Hopefully everybody here I can get through this. All right. Patient with a second opinion. Okay. Maybe requested by the insurance company. For example, workers' comp. Insurance company is requesting that the patient see another provider other than their provider. Modifier 32. Modifier 32 description is mandated, requested, right, by the insurance company, or usually it's workers' comp. You would append modifier 32 to your E&M code, like the insurance company. Okay, so someone asked if they request and don't get, they better get a response. If that doctor saw that patient, and in order for that doctor to, he has to prove that he did a response. And plus, if he goes back, let's say you did that consult with that doctor, and you're now an established patient. You can't just use consult codes one time. Okay, so everything else, if all your other visits to that provider are going to be subsequent visits, right? So established codes once you have to do your follow-up. Yes. This is being recorded, so if you have to drop, I'll still be going, even if I'm here by myself, guys. One thing to mention, Medicare no longer uses consult codes. So people are like, well, how do they establish whether it was the actual consult if they're not using consult codes? They would use the new patient codes, remember the new office visit codes, and then they would add modifier AI, which I like to say, hey, I am the responsible party for this patient. That's my patient. Get it? They use Medicare uses for the principal provider of record because they no longer use consult codes, but they won't ask you this. Okay. Moving on to the ER, emergency room. Again, this is, even though some people go back and forth frequently, there is no distinction between, again, the ER, the emergency department. They may just say ED sometimes in your question. Yeah, if it's a Medicare replacement plan, then yes, they will use AI because they follow Medicare's guidelines. Facility 4 hours a day. And it has to be, they have to be able to offer under the direction of a physician, life support for it to be considered an emergency department. And it needs to be attached to the actual hospital. So urgent cares like to say their emergency departments, emergency should be open 24 hours if they want to be, and most of them have business hours. So there's no way it could be a emergency department. Okay. So again, with the ER, same thing. They have key components. Those codes are 99281 through 99284. I'm sorry, 99281 through 99285. Critical care. Now we get to switch it up a little bit, just a little bit. Critical care, which starts, you see there's a lot of reading to do on that, onto things bundled into your critical care codes. Now, critical care, and it will say the critically ill patient in your question, so you know to use critical care. It is time-based, right? Everybody see that little box? If you turn the page after they give you the description of what is covered under critical care, you'll see a little box and it says total duration of critical care codes. Less than 30 minutes. If it's less than 30 minutes, then you're going to use it, you're going to use wherever you are. So if the critical care, let's say critical care was administered in the emergency room. Well, if it was less than 30 minutes of critical care, time code, right? But if it's 30 to 74 minutes, then it tells you, it has your formula here, you use 99291. So what you're looking for is the amount of time, right? Because it even tells time. So for example, in the chat box only to me, please. If a patient was seen for an hour and 30 minutes of critical care, what would my answer be? An hour and 30 minutes. Anybody? An hour and 30 minutes. What would my answer be?
Times 1 and 99292 times 1.
Okay, let's mute your phone. All right. An hour and 30 minutes. I'm still, okay, I see a few people. Okay, all right. And 99292 times 2. Don't forget to use the chart. Don't forget to use the chart for the time. Okay, and if it goes way over 3 hours and 15 minutes, do you see there is a add-on code there? Well, no, you just keep using your 99292 tactically. No problem. So if they don't say critically ill, we need some keywords. Right? So it impairs one or more vital organ systems, such that there is a high probability of life threat, basically, right? Or it will say their liver was punctured, but it was vital organs, something that's going to make them, if they don't address it right away, if the patient is going to die, then of course they're going to administer when I send this off. When I send this off, that you guys make sure you put those keywords on that page. Acutely impairs one or more vital organs or life-threatening. Okay, and it tells you everything that is included. Basically, everything is included in critical care, all the services. Okay. And we're going to talk, while we're on for children, there's a different set of critical care codes, which we'll get to in a second. However, regardless of the age of the patient, if a critical care administered in the emergency room, these are considered adult critical care codes, the 99291 and the 99292, because the children have their own. But those codes are when they are having critical care in the intensive care unit, the critical care in the emergency room, then you will use these adult codes. I'm going to say that again. Regardless of the age of the patient, if they are having critical care administered in the emergency room, ED, emergency department, critical care codes, which are 99291, 99292, depending on the amount of time, right? If the child is having critical care they have their own critical care codes, which we'll get to in a moment. So that's why it has here guidelines containing instructions for pediatrics. So neonatal, again, is 28 days and younger. Okay. And then pediatric is going to go from over 28 days to 5 years old. And I'll give you the breakdown of those categories in a second as far as the aid. It does, however, say critical care and other E&M services may be reported on the same day by the same provider. So they could have came in like a regular visit, not a regular visit, but they could have abruptly happened. So they could have had that E&M time, the regular ED service, and then you're going to monitor, and then you'll look and see how much time of that was used for critical care. P5, right? Modifier 25 is an E&M modifier, and I'll talk about that. I don't want to get into that too deep right now. I'll get into that towards the end when I talk about the other modifiers. All right. So again, critical care time is, critical care services is based on time. Time increments. Doesn't need to be continuous time, but the provided time that was spent for critical care. And you'll see a couple of questions that will distinguish that in your study guide. And that once he's gone to go write up his notes on what happened, that's not part of critical care. Okay, so we already know less than 30 minutes. We're going to use the appropriate E&M code. First 30 to 74, 99291. Each additional, so increments of 74 minutes is going to be 99292. And it says table and guidelines to help, so we just looked at that table. One more before I move on. So the patient came to the emergency room department and had 25 minutes of critical care. What would my CPT code be? 25 minutes of critical care in the emergency room department. And in the emergency room department, they had a detailed history and exam, and also medical decision-making of moderate complexity. Good, Elaine, thank you. Yes, yes, yes. I like that you guys, okay. Right, good. So because they weren't in the, they didn't have more than 30 minutes of critical care time to use the critical care codes. So you don't let them trick you, because you know they'll do that. I just have to try and trick you first. All right. Nursing facilities, they may not ask too much about the R codes for nursing facilities. If you look through your book, if you look at 99304, again, through 99304 through 99306, again, they still have those key components, right? This is when they're coming into the nursing facility. And then you can see they also have your nursing facility discharge services, which are 99315 or 99316. And again, that's based on time. Okay. So it's similar to the hospital, but they're nursing facility. And then they have the 99318, which is their annual assessment, which is required by law that they, give them an annual assessment. Just like when you go to the doctor's office and you have that welcome visit. Okay. And I like that they have identified nursing facilities. They also include psychiatric residential treatment center there. So, because that's not going to show, falls under nursing facility services. domicile rest homes or custodial care services also includes ALS or so the patient's either new or established. Okay, so the provider can see the patient in one of these types of facilities. So where for you? And those codes are 99339. As you can see, there's no, when it says no medical component, meaning that you don't have those three key components, the history, the exam, and the medical decision making. This one here is based on time. Next, we have home services. Now, then we go back to the key components. You have a new patient, and you have your established patient. You get the idea. So you can see the main thing in here is to understand those key components. Now, prolonged services. So it tells you here, if you go down to prolonged services on the screen, it says it's direct patient contact or without direct patient contact. So with or without direct patient contact. So the settings are usually outpatient, and it can be add-on codes. So you're like, okay, well, if you're using add-on codes, how do I know when to use prolonged services? So it gives you after CPT code 99350, that's where code range, which is 99354 through 57. And it tells you these codes are used when a physician or other qualified healthcare professional provide prolonged services involving direct patient contact, that is service, in either the inpatient or outpatient setting. And that will say, it will maybe say they spent an additional, let me see how long it is. Let's turn the page. Do the patient about stop smoking cigarettes, although there is a code for smoking cessation and there are CPT codes for that. But it's a side patient came to the office, basically. Okay, or it could be you're not taking your insulin. I'm going to educate you about this. So it would, and then they have, let's see. So they have it broken into with direct patient contact, and then they have it 99358 and 59 is without. So when it says without direct patient contact, they could be possibly talking to another healthcare professional. Of course, it has to be documented. And a date of when they saw the patient in reference to the without patient contact. So just make sure that you just kind of look at those and see when. Because code 99354 or 99356 is basically for the first hour, depending on the patients, fall into that category to be able to use those codes. You may have a question. I think there's a couple on your in the study guide that I'm going to send to you where you'll be able to utilize the prolonged services codes. Okay, so they say it's similar to critical care, these services here. And standby physician services, which starts 99360. We mean standby. Like, let's say there was a person going to deliver a baby. Now, the provider doesn't need to be in the facility. He can't be like standing by at home, right? So he has to be at the hospital. All providers would be billing standby services. But this would be like mom that's how she's getting ready to deliver. a baby. And so her OB is obstetrician is like, look, I need you to be here just in case she has some difficulty. So that means that additional request of the other provider, and he does need to be there just in case, but it only can report if he's there longer than 30 minutes. So that's standby services. Of what falls into standby services, you may just need to glance over that, but it will be pretty clear to you in the question when to use it. Caseation management. So when I say anticoagulation management, does anybody know what disease that's pertaining to? Parker, answer the chat box. When I talk about anticoagulation or somebody's on warfarin, what disease do they have? Yes, very good. Those are blood thinners. Okay, so Tori, that is correct. Good. So they do have codes for case management on that. And it does, they get testing, sorry, 4 of them, purple bullet points here, to tell you what falls under anticoagulant management. Okay. Medical team conferences is exactly that. It needs at least 3 healthcare professionals. It does give you a little bit of information on when you would use that. I don't think they'll ask you any questions in reference to that. Mostly it's going to be on those office visits. So you got to make sure you understand those inpatient, outpatient, even the hospital and critical care questions. So you do see how big this section is. But we're doing well. So I know you'll get something from like a new patient, an established patient, critical care, you know, a couple of questions on those consultations, being ready to touch on. The care plan oversight services, that's to do more with home health. Okay. Billed on a monthly basis. Doubt if they ask you questions in that particular area for care plan oversight. As you can see, like CPT code 99374 is for just like supervision. Those are supervision services, and those are based on time. Okay. So I do have these in red because like your annual visits, right? So if you look at 99381, now we're starting to look at age. Age becomes a factor. So at the top of that page, forget that the age is a major component. So like I have on that second bullet point, it's divided by whether the patient is new or established. So you'll be able to determine that when you read your question, and then by the age of the patient. Okay. So if I was to ask a question, or my scenario to you is a 55-year-old is returning to the provider for their annual physical exam. I said 55 returning. They were here last year, if that helps, and they're coming in for their annual exam. What would that answer be? I bet you guys just love this section. But as long as they have it like this, I think you guys will be fine. I didn't say they did any labs, so please don't give me any labs. I just want the, or anything else, I just want the annual visit. Because now you're thinking medical billing. Good. Correct answer would be 99396. Billy, what did you have there? Is that an EKG? All right. To that annual, then you would append modifier 25 to the E&M code. And for counseling, again, and it's based on time for counseling. Online medical evaluations, which is actually becoming quite popular. Online, some people will say, well, online medical evaluation, why? But if you are a patient and you are possibly in a rural area and do not have direct access, I know Medicaid covers a lot of these television locations. Newborn care services, keep it moving. So they have, look at this, medical disability evaluation services. So when they're coming in, so a lot of people just code for just medical disability. Like there's like 3 codes. I'm like, can we find that contract? Right? And then for workers' comp, 99455 or 99456. 2 codes for workers' comp. And it just tells you what needs to be done, what the we need to find one of those. How hard could it be? 2 codes. You could do those all day. And then you have your newborn care services. Remember, newborn is considered 28 days or younger. And it's going to be separated by whether they're just coming in or they're having subs. So you have your deliveries. And then we go on. Do you see all this reading here for inpatient neonatal intensive care? Basically, what I want to tell you about this particular page is that basically every service is rolled up into here, I think, except for CPR. 50 is in here. Because it tells you, I think if you flip the page, it gives you a list of all the services that are included with neonatal critical care. It gives you a list of all the procedures that are included in that one CPT code. So remember, you're going to use these codes if the critical in the ICU, right? If critical care is being provided in the emergency room department, regardless of the age, you're going to default back to those 99291 and 99292 codes. Okay, and if you read through, you will see all of the things that are included in those, what's bundled into those codes. And they even have a pediatric critical care transport. And you see with physician is physically present during the transport to the facility. This is the only time you can bill these. Doctor has to be in the ambulance. And under 24 up to 24 months on that 29th day, 29 days to 24 months is pediatric, right? And when does it start? It starts when the physician assumes responsibility and ability. And it's built in increments of 30 minutes. And then we went to inpatient. So that's where I was telling you everything's code for that critical care time. It says it includes same procedures listed in critical care for 99291 and 99292. Okay, well, if it does that, then you can, if they have CPR, which is 929, build that in addition to the critical care code. Also, they may say a line place, endotracheal intubation. That's, I think actually that might be included in theirs, which is 315. Yeah, that's included. Okay, so endotracheal intubation is included in the pediatric critical care, but not in adult critical care. Okay, so that means if the service is being provided in the emergency 9291 or through 99292, depending on the amount of time, you can also capture if they say they had CPR. You can code for that, which is CPT code 92950. And you can also code if they have to place CPT code 31500 in the ER. But 31500 is included in the critical care code if it's a child and it's being administered in the ICU. The person is, or the child is, when critical care is being administered. Okay, so again, neonates is 28 days or younger. Infant, 29 days through 24 months. Very important. Location is very important. And young child through 5 years of age. So 2 to 5 years in age. So that's 24 months and 1 day all the way through 5. I guess they're adult once they reach 6. What would they be after? What are they between 6 and 17? Anybody know? Only friendly responses, please. I'll take Brad. All righty. Initial and continuing intensive care. So these are, if it happened, that's intensive care unit. Like if they did critical care in the ER and now they're moving them to intensive care, you have your codes there. Or sometimes they'll come straight into, which starts with 99477. So this is where we're talking about the kids, right? And then 99478 through 80 for subsequent intensive care. How do I select my code? Well, codes are based on the weight of the child, especially if we're talking about neonates, because some of them can just be grams. Please. Let's see what else you need to know in here. And then they talk about complex chronic care. So they revised a lot of this. So I run the chronic care management services, and actually that's a new code. That 99. Oh wait, I'm looking at my old book. I'm sure there's no red dot next to yours for the 99490. Advanced care planning. Here's when the patient wants to discuss how much time they're spending talking about their living will, giving over power of attorney. And you have Trinity going from the hospital and then being transferred to like a nursing home. That's transitional care management. There's codes for that. Okay. Woohoo! All right. So steps again to review, and then we have to talk about the leveling, which won't. I do want to do a few questions too. All right. So when you're leveling or when you're coding, these are going to be some of the steps. Because remember, we were 8. Winnie, that's nice. Young adults. Okay. I'll take that, I guess. But even if they're 7 or 8, well, some of them may be. But all right. Anyway, steps on coding. What steps do we need? So, of course, we're going to review the guidelines. We need to know the location. We need to know if they're new or established, if it applies. And what we're going to focus on now, hopefully I can wrap this up in 20 minutes, but you're going to need to have your pens handy. And we're going to turn back to the E&M section. We have to be able to determine the level of the history, the level of the exam, and then the level of decision making. And we'll wrap up by breaking down a actual progress note. So you can see exactly how everything applies. Pages in front of where you have your reference pages. They're called E&M tables. Never really used them. They came into the book a couple of years ago, but it kind of breaks down. You'll see if you're looking at them that they have service, and it talks about the different key components, right? So you may want to take a look at that. That may help you. I don't utilize them, but I never had anyone that says, yeah, I love the table. They usually do what we're about to cover. So let's go through that. Okay. So when you are leveling, there's 2 types of guidelines, and it depends on where you work. And it depends on your specialty. I say most provide 5, but if you're a specialist, some of them like to use 97. If you want to know, well, what are you talking about, the guidelines? You can put, you can Google CMS E&M coding guidelines, and it's a down sheet on there for you to do this, what we're about to do. So again, the 3 key components, you see there's, up here it says there's 7 components to consider 3, which is the history, the exam, and the medical decision making. Time is also a factor. If the provider says they spend more than 50% of their time counseling, the E&M code levels will give you the amount of time that goes into that CPT code. If they say more than 50% of their time was spent counseling the patient, then basically what you're looking for is that amount of time, and that's the code you'll choose. Okay. Now, the history, the exam, and the medical decision making. All right. Again, the 3 influential factors: history, exam, medical decision making, influence the level of SIR. If more than 50% of the time is spent counseling, then that will dominate the encounter, and you'll just select your code based on the amount of time spent counseling the patient. So when I said you need to turn to your green page in your E&M, can someone type that page in the chat box? And I want to make sure we're on, it may be page 4, I'm not sure. Yes, okay, good. So we're on the same page here. Because they have a code, I just said. This book is really old. I have CPTs all the way to 2004. I still have them. I don't know why, but I still have them. I guess because they come out so often. Starts your evaluation and management service guidelines. Okay. This is a good book. I hope all my notes are in here. Oh, okay, let me grab another one. Yep, we can use this one. Okay, so do you see where it says chief complaint? So you'll see chief complaint, and basically the chief complaint is a statement. That's when the patient comes in, and now they're stating what's wrong, and they're coming in and they're describing the symptoms and the problem they're having. So the doctor writes that down as a starting point. Right? And they have people that just follow doctors around in the ER. They're called scribes. And scribes basically are providers' documentation. That's all they do. So that can be quite interesting. So a lot of nursing students will have jobs as scribes while they're going through nursing school because they'll follow the provider around. It's like a laptop on top of a cart, and they're just doing this E&M. As you can see on page 4, before you do that, it still gives you the definition of what a new and established patient is. Okay, we'll reiterate it there. And then on page 6, counseling, family history, HPI, I'm going to talk about that. So on the top of page 6, listen to what I'm saying, the heart is everything for the history, the exam, and the medical decision making. The exam and the medical decision making are going to be the easiest part to me. The history has 3 parts to it, right? Next to history, so I can keep myself on track. But on top of page 6, I want you to write history. And I also want you to write history on the top of page 7. Okay. So the first part of your history is going to be the HPI. So on page 6, history, and then it says history of present illness. That is your HPI. So I want you to write HPI there, so you know that's your HPI. And you also want to put history 1 or number 1, because you know that's going to be your first part of your history component. Now, if you were to read that little paragraph there, I just kind of simplified it on the slide. But basically, the history of present illness, the provider now, this is the dialogue once you came in as the patient and the provider. So when I say the history of present illness, you'll notice my bullet points, which they are already in that little paragraph, right? There is 1, 2, 3, 4, 5, 6, should be 8 items listed in that one HPI paragraph. They just put them all in the sentence. See that? All right. So I kind of broke it at the bottom. Do you see the bottom of my screen? There's 2 things I want you to write on that page next to HPI. The 2 terms are brief and extended. Okay. And next to brief, you're going to put 0-3. That means from 0 to 3 elements. Okay. And next to extended, you're going to put 4. So what do I mean? So now the provider is talking to the patient and they're having dialogue. And so what I did on mine, which again, I'll be forwarding this to you via the recording, so you'll be able to watch it and stop it. So don't get panicked. So remember, when the patient's coming in, she's talking to the provider. And provider, he may ask, depending on the conversation, the patient is going, he may ask, where does it hurt? And about the area of the body. And so that would count as location. So remember, we're trying to select how many bullet points or how many bullet points the provider documents, and that's how you're going to come up with whether the HPI was going along. You may not ask all of these questions. Your job, this is if, okay, this step of the leveling is if you don't have those 3 key components already identified in your question. You have to read the progress note and level it yourself. So this is what we're doing right now. If those 3 key components are not available, we are going to abstract from the progress note and come up with the level ourselves. And this is great. Most of it, I like to do it because sometimes if you apply for a particular position, yes, on the AAPC side, they may give you what those 3 key components are, but most of the time, they will not do that documentation. He's not going to say expanded, problem focused. Some will, depending if they're using like a particular EMR, EHR system, but I want you to understand how we come up with this. So if you had to discuss it intelligently, right? You understand. If they ask you what's the HPI, then you're going to say, it's talking about the description of the patient's illness, where it hurts or how it feels. So again, if the patient says, okay, well, I started feeling this about 2 days ago, that's going to equate to duration, right? And he say, how does it feel? It may be stabbing, throbbing. And, everybody knows this when the provider's like, on a scale of 1 to 10, how bad does it hurt? Okay, that's a severity component, okay? Timing is when it happens, morning or night. We're talking to each other, the provider and the patient. And he's like, well, what were you doing when this happened? And I just wrote there, I injured my ankle while running to class, right? So that's what you were doing. That's the concept, basically things that happen to make the condition feel a little better, like, oh, I take 2 aspirin, I use a cold compress. That's considered a modifying factor. Those will say, okay, my ankle, is hurting, but now I'm starting to feel pain radiate up to my knee, because that may give the provider an indication that he may need to run an additional test, maybe like an X-ray, to see if anything's broken or if there's any type of fracture. And don't worry, because again, this is being recorded and I'll send it to you. Next to the HPI, you're going to have brief, 0 to 1, extended, 0 to 4. And we're going to have like a little scenario so you'll know how to play. So remember, there's 3 parts to history, and the HPI is going to be the first part. Okay? So I like to have it outlined this way because in the book, it all kind of runs in together into that one paragraph. I was just trying to look in your book if there was a page, like a blank page for your notes, somewhere where you can write it. But as long as you remember brief is 0 to 1, extended is 4 or more, you'll be fine, or you can have it here. You just need to remember with your HPIs whether it's brief or extended. Okay. Second step in your history is the review of systems, which is on page. This is going to be history number 2 in the parentheses on the top of your page. This is the review of systems. So when I say review of systems, I'm talking about body systems. Look on this, right? Review of systems. It starts constitutional, and then it ends at allergic, right? So with the review of systems, let me see, do I have, because you don't need to see all the body systems. You have that on page 7. So there's 3 categories. Just like when you wrote brief is 0 to 1, extended is 4 plus, this is what I need you to write on this page. Look at the red bullet points at the bottom. Equals 1 body system. Okay. Listen also, when you're counting these systems, if the provider asks the patient, if the answer is either yes or no, due to the fact that he addressed a particular, so that's why it says a problem pertinent review system is a positive or a negative response. It's either or. It doesn't matter if it's a positive. If he addresses a particular body system, it's going to count. So let's look at the text one. Let me put this down here. It says, a single element cannot count towards the HPI. Remember, your HPI was over here, and the review of systems. So if they say, where does it hurt? Oh, my knee. I'm feeling knee pain as the location for HPI. Then you can't use knee pain with a limited range of motion or swelling in your review and check off musculoskeletal system for your review of the system. All right, so you won't be able to count it. Okay. So I just wanted to give you an example of that. So again, you're going to write problem pertinent -1. That means I'm only addressing one of these systems that are listed on page 7. Or you can just put extended is from 2 to 9. See, I even highlighted it in red for you. That means 2 to 9 of the systems that are listed. I think it's 14. 1, 2, 3. If he asks questions about 2 of the 9 systems, 2 to 9 systems, then it's considered extended. And then a complete review of systems is 10 or more. So you can just put 10 plus, right? And then they're talking about 1 body system. Extended 2 to 9, and complete is 10 plus. Good. We're all right. Everybody good so far? And remember, we are on the green pages. We're not in the actual E&M section right now. We're looking at the green pages, which are the guideline pages. So right now I'm on page 7. Okay. And then so complete is 10, 1. Last part of your history, the third part of your history is called the PFSH. Okay, so that stands for past family or social history. Okay, PFSH, they don't have them in one area, but if you notice the past history is at the bottom left-hand side, right? It says past history. You might want to put 1 or A, since we have 1 numbers already. We could put A, and then 6 above the HPI. You could put that as B. I'm going to do the same thing in this book, even though it's over. So family history is B, and then social history is back on page 7, past history. So let me tell you, so there's 2 categories, right? I'm sorry, there's 3 categories. You have your past history. But just like we did our problem pertinent with the review of systems, okay, on the past, there's 2 categories for this particular section, the PFSA. Yes, pertinent, that means 1 to 3 elements, and I'm going to talk about those elements. So you're going to put them pertinent, because problem pertinent was review of systems, just pertinent. 1 of 3 components, and then you have complete, which is 1 from each of the 3 components. Okay, so pertinent means, and when I say components, meaning if I just spoke about, let me talk about that for a minute. If I just spoke about past history, and you see all those bullet points there, even if I said, have you had any prior operations? Are you on any current medications? Do you have any allergies? That still only counts as 1. Get it? Because it's only talking about, those are just questions from the past history. It still only counts as 1. Then you go over to family history. They'll ask if, let's say they were being screened for cancer, and they want to know if anybody else in the family ever had it, like siblings or grandparents or parents, right? So that's the health status, specific diseases. You see that second bullet point? Any specific diseases related to problems identified in the chief complaint. Remember, the chief complaint was listed on page 5. So that's the patient talking about their diseases of family members. So basically, family diseases. That's what they're trying to find out, especially if it's a chronic condition, right? And then you have your social history, right? Back on, we're going to call history A, family history is B, social history is C. Okay? So I'm going to put social history C. And you can see the questions. Are you married? Do you work? What kind of work do you do? Especially if they have a knee injury, they're going to want alcohol. Do you smoke? See, again, if they can ask multiple questions from the social history bullet point, but it's only going to count as 1. Okay. So again, pertinent is if they're just asking one of these 3 sections, and come 1 from each of the 3 sections. Somebody's going to say, well, what about if they just ask for 2? It's going to be pertinent, okay? The only way it's going to be complete each. Okay. So that's all of the history components, right? So the first thing we had going on in history was the HPI, okay? Review of systems. The third thing we spoke about in history was the past family social history, and we listed those as A, B, and C. I don't know why I wrote 7 there, but it should be a C. Of your history. So let's look at this for a second. So these are all the things we just discussed in the history, and it gives you the level of the exam and the level of the medical decision making, which we're going to do in about the next 10 minutes, because the next the next 2 are really short. Then we'll be able to get that level, and we're going to talk all the way through the levels. So again, there's 3 parts of the history component. You're going to tell me, oh, that's easy. That's the HPI, right? Review of systems, and the past family social history. And if I make the extended how many review systems do you have to review for it to be extended? Put your answer in the chat box. I don't know why I can't get this thing up. Okay, good. Of course, my mouse doesn't want to work. All right. So what we're looking at right now, and that's fine because I need you to see the screen. What we're right, and it's showing you because sometimes a provider may not ask from each of these categories, right? He may not ask. But if you can see the three columns at the top, that's the HPI, the review of systems, and your past family sort HPI, but he didn't do a review of systems, or he didn't do a past family social history. That makes your level for your history only problem focused. Okay. Picking anything from this slide here, he could do an extended HPI, extended review of systems, and a pertinent history that's going to give you different categories. And this, if you had to write anything in your book in reference to E&M, this would be the only thing I would suggest. Only because you may not remember all the different combinations to get the level. Will you need it? Is that going to stop you? But is it a good way to understand how to comprehend the history component of those three key components? For sure. Yes, it is. So you definitely want to understand how you do this. So again, this is like the little graph. And again, you will be getting it as far as, but you would need to know brief. See, but we already know what goes into brief and what the things are we need to ask in reference to history, right? So just keep that in mind. In order for them, if they do no review of systems, if it's no on any of these, right? And then once we get to comprehensive, look at the bottom, because I have to do I association with what I'm looking at, right? So if you notice at the bottom, in order for it, or you might just be able to just put the letters to understand, but in order for it to be comprehensive, you see that review, you have two completes, right? So C and C equals C. Get it? C, complete for the review of systems, complete for the PFSH, comprehensive, as long as the HPI is extensive. Right? So we're always going to know comprehensive and problem focused, right? Because problem focus is going to have like two no's, meaning I didn't review the systems and I did show history. Right? And I did a brief HPI. I'll look at three elements. The only two you're maybe going to have to kind of focus on once you do a little practice, right? You have to focus on are those two in the middle. And once you see detailed, you maybe can get, because I'm looking at it and I'm like extended. All right, that's going to be detailed. That's like a level 3. Remember how bullet points, this is where this is coming from. This is how you just got that first line to determine the level of the history. And again, you're going to get this and you're going to practice with it. And we're going to talk about it. So here's an example. This is just to pull out user-friendly for you by making the words jump out. Okay. So this is the first part of your progress note. It talks about the history. And remember, the patient comes in, the CC is what they have. It's coughing, right? So now the provider's starting to ask questions. Well, not the patient because they're 2 years old. Maybe mom's saying patient was coughing. Okay, so a barking cough, right? So barking is what? Barking is going to be like the quality, how it feels, right? Occurring at night. Okay, so you're thinking these are the 3 parts listed in HPI Review Systems PFSA. So what you should be looking at right now is page 6, because you're looking to see, okay, out of the things they have outlined here, barking is going to be quality, right? And then, what's wrong with this book? Trying to get it to come up so I can see your answer. Oh, there we go. Yay. Oh, look, you got the answers. I didn't even see those. So I'm going to ask you, it says occurring at night. Good. The time, that's the timing, right? And what else do we have here? It's been happening for the last 2 days. You guys are getting it. Duration, right? Duration is how long. It may take you a while to look at it, but you're like, yeah, duration, and I'll take that, right? Now, so we're done with the HPI. What's next? Let's see, what's next? We're going to do review of systems next, right? So it's been a little time consuming because you have to kind of pick it out and figure out which one. But after you do repetitively different types of questions, it becomes a lot easier. Okay. So now we're trying to count. Remember, review body systems. There's 14 systems here. We have to see which one. We have to count how many. I will tell you, look at that 3rd bullet point on number 7. So that counts as one. Hcpcs, they have something wrong in here, but I'll bring that to their attention. But ears, nose, mouth, and throat, that 3rd bullet point, that counts as 1. Okay, so here we go. So review system patient has a runny nose. Okay, so that's your no ear pain and slight fever. So the ears there, the nose. Did they say anything about the throat? No, just the nose, ear pain. Look up on your list on page 7. You'll see that falls under constitutional, right? So that's constitutional, and it says no complaints of chest respiratory. So if I was to ask, which or how many systems did he review in the chat box, tell me. Ooh, all right. One more thing to go. All right, so remember that. So you have to remember, okay, he reviewed. So what would that make it? That means he would have done an extended review of systems, right? Okay, and we already said he had 1, 2, 3. So his HPI was brief, right? We agree? And then his review of system was extended, right? And we have 1 more left in the history category, right? And that's the, darn it, this thing is all over the place. All right, so the past family social history. So here's what we're talking about. Patients up to date on all immunizations, right? Currently take Zyrtec daily. No known allergies. I didn't hear them ask about, for the PFSH, there's only 2 categories. It's either pertinent or complete. Which one would it be? Pertinent? Good. I know you guys are doing it. Maybe it just takes you a long time to write pertinent. Good, good. So now you have to remember, because we have what we need to get our history level, right? You got, let's think about it. You have your, what was first? Was a past family social. So you need your HPIs, your review of systems, and then your PFSH. So your HPI was brief, right? Your review of systems was extended, and your PFSH, we'd all agree with that and know how we got there. All right, so let's look at it. Remember the little history graphs? All the little, so this is basically the same thing. So what they have colored here, meaning how captured a brief. See what they did? They highlighted the two that apply in each of the rows. In each of the HPI, review systems, PFSH. So in the HPI, we highlighted, yes, it was brief. So we highlighted those two. Right? They did an extended, so we have to highlight down to extended. Right? And then in the past family social history, we highlighted down to pertinent. Right? So basically, what we're looking for, we would have loved to have given, right? So we want to get what all matches, right? So what do we have here? So we have a expanded problem focus because we got all three. Remember all three? So we want to match this. This is, these are the levelings now to get the level. We're trying to get all three in a row for the leveling, right? That's level. If I went down, it wouldn't be level, right? Leveling is all three matched. And no, we're not going to drop to the lowest for the level. They did do a problem pertinent. Actually, they did it extended, but we had to drop back, right? Because we need all three to match in the row. So I hope everybody understands that, or you at least have an idea of what we just did, right? So it was an expanded problem focus. And that's why I said this would maybe be the only little thing I'd want to draw in my book, because the other two you'll be able to get, and I'll show you. So we did the history part. Now on the, right? So I'm looking at page 9 right now. So on the top of page 9, you need to write exams. I know you're just looking all over the page. This is where your exam component comes from. Okay. And so, I'm looking at the right thing. Yeah, gives you all the body areas there. Where it says determine the extent of the examination performed. Okay. And if you look at like my slide, it has body areas. It says examination may be body areas or organ systems, right? So you just have to think about where that organ would be. But anyway, if you see above those bullet points in bold, it has problem focus. So these are already get to each of these bolded. So next to problem focus, let me go back. Next to problem focus, I want you to write one body area or being examined, right? Next to expanded problem focus, I want you to write 2 to 7. And next to detailed is also 2 to 7. I think I'm missing a slide. Oh, there it is. Expanded problem focus, you're going to write 2 to 7. Next to detailed, you're going to still write 2 to 7, but they're going to do an extensive examination in one of those areas. In one of those 2 to 7, they're going to spin it. Right? And comprehensive is going to be 8 or more. So I just put 8 plus in my book, right? So you should have problem focus 1, expand comprehend detail 2 to 7, 1 in detail, and comprehensive is 8 or more. 8 or more. All right. So here is the exam. That was easy, right, on the exam. So now we are, that's it for exam, no big chart, all of that actually being evaluated. It's the history that has those three components, which is the most time consuming of the leveling. Now with the exam, I already has in the progress notes the body parts. Those are the ones that are in, let's see what they did. So part of the exam, so constitutional, he looked at vital signs, right? Yeah, this is part of the exam. The review systems. So they have the vital signs, which is constitutional. They're going back to 7. They're just going what they were doing when they were looking at these body areas. So your vital signs is constitutional. That's 1. PERLA. Anybody know what PERLA stands for? Vision, right? So that's your eyes when it says PERLA. And then it has ears and nares. That's so PERLA and the eyes are in 1, right? And then you have, so that's ears, eyes, ears, nose, and throat. Okay, so that still counts as 1. Now, eyes is the system by itself. So eyes is 1, and then they have ears, nose, and throat. So that's going to be 2. So far we have 3. And then they did respiratory, 4. And then they have integumentary there. So it's 1, 2. So they did 2 to 7 body areas. Let me go back because I know somebody missed that. Hold on. So again, PERLA is the eyes. And if you look on page 7, if you go back on page 7, it's just breaking it down what they did to each of those systems when he did the exam. Because you're like, well, why is it the same? Well, he has to examine. So he's going to examine the system he's reviewing. So that's what this part of the examination is about. So we're still counting those areas that he reviewed. And if we look at this particular slide, PERLA is the eyes. I put the ears, nose, and throat in green because they all kind of group together, so I wouldn't get those mixed up. So it's 1, 2, 3, 4, 5 on his examination. And if you look back on page 9, okay, where does 5 fall? It doesn't say he just extended anything, right? So it's just going to be a regular expanded problem focus visit. See? Expanded problem focus, because he reviewed on that exam 2 to 7 body areas. Just so you guys can see that. And the reason I had to count them out like that, because if you look, you would have to know, because you could have just said, okay, Constitution would have maybe just only counted 4. Maybe only would have counted 4. And I shouldn't have had the eyes. Yeah, the eyes are separate, right? So you had to, but that falls under the HE. Usually we just, or EN, it should be EN and T. But we also have to consider the eyes. So that's also reviewing the eyes. So you have to count that. That's where the extra one came from, focus. Now, the last part of the leveling, and then we're going to put it all together so you can see, it's going to be your medical decision making. But I have my own way on how I do that. So I want you to turn to page 10. Okay. So medical decision making, you'll see on page 10, there's 3 bullet points there. It says the amount of complexity, meaning the way they're reviewing the medical records, if they have to order any tests, and the risk of significance, the same thing that you see on the slide. What I want you to do, where it has the table at the bottom, okay, right where it says number of diagnosis, symbolizes number, and I want you to just put treating diagnosis or treating DX. So that means number of diagnoses they're treating, right? So let's think about it. If it's minimal, I want you to put, and I want you to put next to limited, 3 next to multiple, and 4. That means 4 or more diagnoses next to extensive, right? Go over to where it has risk of complications, morbidity, or mortality. But I have you write a few things there. Let me see if they have that. They don't have it here. It's my own thing. All right. So next to minimal, I want you to write gargle. Like I'm using this as sore throat, right? So he didn't even prescribe anything. He's like, go home, rinse your mouth out with some, I don't know what a remedy is, hot salt water or some Listerine, right? So that is going to be minimal, something that you could just do to take care of it by yourself. Okay, that's going to maybe be like a over-the-counter drug, right? Over-the-counter or OTC, over-the-counter, something that you can buy in the store to treat it, right? A prescription, something that's been prescribed, right? And high is going to be like, no, we need to have surgery. Okay, so now you see the differences. That's just my example of minimal, low, moderate, and high. Okay. So those are the 2 things that I look for when I send, or how many diseases are being treated. Now, remember, his chief complaint was just a cough, right? He didn't have any other additional diagnosis here. Chart in the chat box. What would you have as your type of decision making? Let's see if you've come up with the right thing. What type of decision making would you have? Anybody else? Yes. 2 more and I'm happy. Yes. 1 more. Yes, I'll take minimal. I'll take minimal, but I was asking for the level, the type of decision making. I know you're on the right line, so I'm happy with that. So here's the whole thing, because we just wrote down a progress note, right? So chief complaint is a cough occurring at night for the last 2 days. Review of systems. Okay, what's going on my review of systems? Okay, on the review of systems, patient has a runny nose, ear pain. We already got that. So, and then we did a PFS. We went through that. We figured out the exam, the components of that history exam, and also the examination itself. Okay. A&P does not stand for anatomy and physiology. Okay. So what they came up, the assessment and plan, usually you look to see what the final diagnosis is, right? So the patient's chief complaint was a cough, but after the provider assessed the patient group, right? One diagnosis. And then he says, hey, go home, use a cold air humidifier, and then come back to the clinic. So nothing big, right? That's something you could just get. But one self-limited minor problem, no data should be reviewed or ordered, so that means the risk is low. And we did already determine, well, they said low because they made them go to the store and get that cold air humidifier, so that would have fallen in the low in your little chart, so that would have been low, and that's not something that would be prescribed. That's something you would buy over the counter. And so it needs all three to match, so we dropped back. Okay, so we had to, basically that one's 2 out of 3. Right? So for that medical decision making, it was straightforward. So now you gotta remember everything that you came up with to get your level. So your MDM, we said it's straightforward. Anybody remember the other 2? We'll get that. And then any contributing factors. So here we go. So remember our history. Look at that. This is great too because it gives you the level of the visit. This is another table I like because at least once you know when you come up with your history components and you find your exam, you plug them all in. So in we're like, I really like this. It wasn't that bad. Just got to get some practice. There is a score sheet that I said you can download from CMS website. Actually, when I send you your attachment tomorrow, I'll just attach it so you can just see it, right? Because you can't use it on the exams or friendly. So here we see that it must be an established patient because you can see the level of the visit. They're talking about an established patient, right? Because there's no 9920 for you to think it's a new patient. So remember, with an established patient, the components, right? 2 out of the 3 components. So we already knew the history was expanded and the exam was expanded. And let me just tell you, when it's an established patient, it helps you. So you can double up on whatever that level is. You don't even have to look at the MDM, except for when it's a new patient. So with that being said, the history, the exam was expanded, and your medical decision making was straightforward. But because it's an established patient, you only need 2 out of those 3 components. So what would my final answer be? Chat. Come on, I should see more than that. Who's sleeping? Wake up. Okay, give me the final answer. I need 2 more people. One more person. All right. Otherwise, I start all over. No, just kidding. All right. So it says here, this is an established patient. We already knew that 2 of the 3 key components. So your final answer would be 99213. Very good. All right. Just to wrap up on the modifiers, modifier 24, 25, 32, and 57. I'll just 24 basically. Remember, if someone has a surgery, usually if they have a surgery, whatever happens to them, the 90 days after the surgery, then it's going to be all rolled up into it's going to be called the global, right? So whenever they pay for that surgery code, which we just, even if they went to the office, they would be like, oh, your office visit is the global period, you can't get paid. Now, if they have an office visit that's not related to the surgery, then you'll build an E&M code and then you append modifier 24. I know it's the global period, but this visit, today's visit, has nothing to do with the surgery. That's when you append modifier 24 onto the E&M code. Modifier 25 is basically, let's say I came in for an annual visit, right? And but then he's like, hey, what's going on your forehead? What's that wart right there? That's something totally different, right, from the annual. So we're going to address the wart, whatever's on the forehead, and then we're going to put something separate. It's separate from my annual visit that I'm addressing here. That's what 25 means. This is a separate procedure. My exam and something else happened, so I'm putting 25 on there to say this. If you don't put that 25 on there, they're going to deny it if you do another procedure on that same day the service as the E&M. So you got to make sure you add a modifier 25. Modifier 32 we spoke about a little bit, right? That's when the insurance company mandates someone to get like over here. I need you to go to this provider. It's work related. I'm sending you here. You append modifier 32 to the CPT, to that E&M to say, hey, this was mandated by the insurance company. Remember, we can get the office visit paid and the surgery paid if the provider puts modifier 57 on that E&M code, right? So not if he goes, not 57 to say, okay, you're leaving the office, you're going to leave the office and you go straight to the hospital and get surgery, then the office visit and the surgery will be paid if the provider appends modifier 57. Or if you're like, oh my gosh, you need to have surgery tomorrow, then you put 57 on that hospital admission code, as long as that patient is going to have surgery the next day. Decision for surgery within 24 hours. So I love modifiers, like I say all the time, because it's giving you an idea of what else you need to look for in your question, right? So if you see CPT codes and you see if it's going to be having surgery within 24 hours in my question, so you know that's the one you're going to need to choose. Because what they're going to do is put the CPT, one with 57, one without, and they need to know, do you understand why this is here? And when do you use it? When determining E&M service, you got to make sure you read those guidelines.